Good afternoon, everyone. We'd like to share the result of almost 30 months of rehabilitation work in patients suffering from inflammation tendinopathies, including post-traumatic or overuse ones, and expand on previous case studies and follow-ups presented in Congress reports. Tendon composition and structure are different in tension and compression areas. Tension segments have a better response and regenerative capacity than compression area. The continuous process of cell renewal enables tendons to gradually adapt to different workloads. In the case of damage or rupture, the regenerative capacity is very slow due to the poor vascularization. So this is the fundamental problem. In human tendon at birth, collagen represents about 35% of dry weight of tissue. When body growth complete, the amount of collagen reaches 80%, while proteoglycans, glycoprotein, decrease. In elderly subject, collagen remains unchanged or diluted slightly less than 75, while the amount of proteoglycans and glycoprotein decrease. The water content of tendon decrease from birth to a later age. Therefore, an aged tendon is weaker than a younger tendon and is more prone to trauma. The highest incidence of tendon pathologies or rupture is more frequent in subjects over 30 years of age. The myotendinous and osteotendinous junctions are the weakest point of the muscle tendon unit and are particularly prone to tension trauma. These areas are very important from the clinical point of view. HA is represented in proteoglycans, glycoproteins, and helps repairing processes. We must not forget that the rehabilitation process is given by the integration among functional recovery, pain control, and treatment of the pathological process. Hyaluronic acid, this is the property, the penetration of synovial mesh, diffusion, paratenon, multifractional bioinduction, relief of joint stiffness, and substitute of synovial fluid. A specific bioinductive multifractionated and linear hyaluronic acid we used from 2 kilodalton to 1 million dalton, and as indication in the IFU for the treatment of tendon, ligament, and muscle disorders. Shock protein APS density from 40 to 90 millimole in electrophoresis produced by tenocytes under the stimulus of a multifractionated hyaluronic acid with bioinductive property are able to restore the plasticity and viscosity of tendon tissue by causing a uniform and longitudinal reorientation of the connective fibers, thus restoring physiological, anatomical, and functional condition. The final catabolite is integrins, simple monofilament proteins with a fundamental role in neoangiogenesis. The main direct action of HA is the synthesis of fibronectin and tenacin, fibrolipid essential for restoring the elasticity and the strength of the tendon. We expanded the range of subjects affected by post-traumatic tendinopathy, treated according to our protocol. 130 patients, athletes and non-athletes, they show clinical symptoms of tendinopathy confirmed by history, examination and instrumental investigation such as ultrasound and physical examination. The symptoms are not induced by chronic disease such as rheumatoid arthritis, autoimmune disease, or chronic treatment with harmful drugs such as quinolones or cortisone. No systemic topical or local drugs such as NSAIDs or corticosteroids were administered. All patients complained of pain and functional limitation with inability to perform activities of daily living or to play sport. This is product we used. We had checkups 3, 6, and 9 months after the last investigation, and we clinically evaluated the patient using a VAS scale for pain at rest and in moment, and measure of active and passive ROM with the FTR method. 18 cases we evaluated the reduction in inflammation by measuring specific marker as MMP3 and integrin at each injection, and after 3 months after the end of the injection, with evaluation of MMP3 and integrin by blood and urine analysis. Ultrasound guided peritendinous injection with 4 millimeter needles were administered in T0, T7, and T14 in athletes, and T0, T14, T28 in non-athletes. Therapeutic dose was 2 milliliter of multifractionated HA with a concentration of 1.6 per with a specific indication in IFU on tendons and with 5 fraction with progressive molecular weight. Dosage and concentration 32 milligram for 2 milliliter, 1.6%. A muscle tendon ultrasound was performed at the beginning and at the end of the therapy. Measuring tendon thickness, presence of exudate area, gap between the injury margins, the alignment of the bundles, and the state of the paratenon. This is a technical indicability. This is interesting ultrasonography of a partial Achilles tendon lesion at 14 and 104 days. There is a good compaction of the interrupt fiber, even if not perfectly reintegrated. There is an interesting debate of how to perform infiltration tendons, the choice between peritendinous and intratendinous infiltration. Some HA products are recommended for peritendinous infiltration only and not for intratendinous, as says the IFU. The paraepitendon works at sheath with the function of nourishment, vascularization, and transport of lymphatic vessels and nerves. In a remarkable number of treated patients, we notice a rapid improvement starting from T1 of all instrumental and clinical parameters, allowing a significant and rapid reduction of the inflammatory state and pain. Results are showed in increasing movement capacity and a rapid functional recovery fundament in the professional athlete. The result is maintained over time, demonstrating the important support the biological self-healing process of the tendon. We have the scale of VAS in first stage, second stage, third infiltration in athletes and non-athletes. The red is pain from 7 to 10, and green VAS from 0 to 3. The same in passive row, range of motion, athletes and non-athletes, and the passive row. In 18 cases, we have studied, as you can see, we can see the decrease in pain and increase in movement capacity are synergistic with the decrease in inflammatory markers. More than 70% of cases with 18 months follow-up still present positive results. In blue, the MMP3, echography, pain, and ROM in yellow. Treatment of tendon injuries with HA promotes a better self-repair process of the tendon, reduces or prevents scar formation that can cause a relapse and impair resumption of sport activities. Treatment with dedicated HA, specifically with a mix of 5 molecular weights, decrease the levels of inflammatory markers in the peritendinous effusion and reduce the symptoms associated with tendinopathy, promoting the self-repair process of tendon. The partial results obtained so far in a population of athletes and non-athletes show a clear clinical symptomatic improvement in patients with tendinopathy. The result in sport patients appear even more interesting in the control reduced 3 and 6 months after therapy. But more studies are still needed, but the results obtained so far appear to be very encouraging. Thank you.